Low back pain in the young athlete. This is a very common problem. About 75 to 80% of high-performance athletes have had back pain. It can be classified as acute trauma, chronic microtrauma, or atraumatic etiologies. Most adolescent low back pain results from overuse or repetitive microtrauma. Acute injury can be in the form of contusion, which is soft tissue sprain and strains, acute disc herniation, or fractures of the apophyseal, or traumatic spondylolisthesis, or vertebral fractures. Also, in severe form, spinal cord injury. Overuse and repetitive microtrauma result from hyperextension mechanism, spondylolytic process. You can get stress reaction, fracture, which is a spondylolysis, and a slip, which is spondylolisthesis. Mechanism from hyperflexion is discogenic low back pain, resulting in annular tear or herniated nucleus pulposus, or soft tissue low back pain causing mechanical symptoms. This image here shows a gymnast hyperextending her back. She's at risk for a spondylolysis, and the image below her shows bilateral spondylolysis. It's a stress fracture in the pars region, most common in L5. Single or recurrent strenuous motion can cause lordotic back pain, results from tight hamstrings. Also, apophyseal avulsion and apophysitis. There's also chronic soft tissue strains and sprains. Atraumatic causes of low back pain include infection, such as discitis and osteomyelitis. Arthritis, juvenile rheumatoid arthritis, or ankylosing spondylitis. Sherman's kyphosis, which is in the thoracic spine. Neoplasms or tumors, which are rare. And referred hip pain, hamstring injury, or abdominal visceral injury can refer to the back. This image shows a discitis and resulting osteomyelitis. When is back pain not just back pain? Well, you must rule out infection, metabolic neoplastic processes with young patients and athletes presenting with back pain. Infection, as the example before, can be a discitis or osteomyelitis. The patient will have a hard time bending over, flexing their back. Imaging studies needed are x-rays, MRIs. Blood work include CBC with differential, SED rate, and C-reactive protein are helpful. Rheumatological, juvenile rheumatoid arthritis and ankylosing spondylitis. Neoplastic tumors such as osteoma, osteoblastoma, aneurysm bone cyst, giant cell tumor, and Ewing sarcoma. These tumors tend to cause night pain, systemic symptoms, and imaging is required. Most common is mechanical skeletal low back pain. This is a strain of the low back muscles, very common, often resulting from tight hamstrings. As the adolescents are going through their growth spurt, bones are growing faster than the muscles and tendons, resulting in tight hamstrings, which will pull on their pelvis and their back. Physical examination. They'll have pain, usually paraspinal, just off the midline. Often worse with flexion and extension, worse with twisting, and they have a negative straight leg raise. If they have a positive straight leg raise, you want to think about a herniated disc. The neuro exam is normal in low back pain due to musculoskeletal reasons. Symptoms suggesting neither nerve root compression nor serious underlying condition. Most common finding on physical exam is decreased range of motion and it's a stated normal neuro exam. Radiographs are not indicated in simple musculoskeletal low back pain. The treatment, education, and insurance, 85 to 90% are better within 4 to 6 weeks. NSAIDs will help, sometimes muscle relaxant, but avoid narcotics. Very rarely is narcotics indicated for mechanical skeletal low back pain. Physical therapy is the mainstay of treatment. Stretching of the hamstrings, strengthening of the core muscles are very helpful. Also, limit the patient's activities. Trunk stabilization exercises, abdominal back strengthening, correcting postural faults, hamstring stretching, aerobic conditioning. These are all important, and I usually write for physical therapy 1-hour sessions for 6 to 8 weeks, and the patients follow up in about 10 to 12 weeks. Herniated nucleus pulposus. This is much less common in kids than in the general adult patient population. A 10-year study of college athletes showed only 7.2% of all athletes with chief complaint of back pain were found to have disc injury or herniated nucleus pulposus. The diagnosis is made by physical exam and MRI, and the management can be very challenging, and there are some controversies with treatment. This imaging that you see on your left here show a herniated disc at L5, S1. Again, see it at L5, S1. Cross-section shows it best. In this picture, it's impinging on the nerve root exiting from the left. You'd expect this patient to have left leg radicular pain. Patient will have focal or asymmetric extension of the disc material beyond the intervertebral space, as seen on the previous MRI. The clinical findings of discogenic pain, key thing is leg pain much greater than back pain. The pain usually will go distal to the knee. It may be associated with numbness, paresthesia, or isolated weakness. It will usually follow a dermatomal pattern. A straight leg raise is positive, as this puts stress on the nerve roots. And there's also, patient may have pain around the sciatic notch to palpation. The most common level of a herniated disc is L4, L5, and L5, S1. The early non-operative treatment involves focusing on pain relief, use of analgesia, usually NSAIDs, activity modification, avoid bed rest, that can weaken the back muscles, but physical therapy is encouraged and required. There's no need for immediate surgery unless there are red flags, such as Akata-Aquinas syndrome, or there's significant neurological deficit. Non-selective epidural steroid injections are often successful, as are selective nerve root blocks. If the patient does not improve with non-operative treatment, then operative management include microdiscectomy or the traditional discectomy, which is a larger incision. The controversy is over when to proceed with operative intervention in an adolescent athlete with a herniated disc. Generally, the results are very favorable, especially if surgery is done early in the first 6 to 12 weeks. 90 to 95% of patients will return to pre-injury level of competition. This diagram shows a microdiscectomy being performed through a very small incision using the microscope. Burners and stingers. This refers to transient brachial plexus neuropraxia, also known as dead arm syndrome or brachial plexopathy. This diagram shows how the brachial plexus is stretched when the head is hit to the opposite side, putting stress on the neck and the nerve roots. You can stretch or compress the brachial plexus, which involves the 5th through the 8th cervical nerve roots and the 1st and 2nd thoracic nerve roots. It's very common in football, wrestling, and hockey. About 70% of college football players have had a burner or stinger. They get severe burning pain and paresthesia radiating from the neck and extending down the arm. And this occurs on one side only. Mechanism most common is traction, downward or backward blow to the ipsilateral shoulder, with concomitant neck lateral flexion away from the affected shoulder. This stretches the nerve roots. Can also result from compression. Occurs by lateral head turning towards the affected side, and also by a direct blow can cause injury to Erb's point superior to the clavicle. Symptoms are non-dermatomal, unilateral tingling in the arm. Usually it resolves quickly in 1 to 2 minutes, though it's been described it can last for only a few seconds and even up to several weeks. Key thing, it's unilaterally. Physical exam, you want to rule out spine injury, that is injury to the spine bone. Make sure there's no tenderness to the spine. Make sure the patient has full cervical range of motion. You'll find that C5 and C6 can be affected. They affect the deltoid and the biceps, so the patient may have some weakness in the deltoid or biceps with a burner or a stinger. And they can have a positive Sperling test. Sperling test is when you tilt the patient's or rotate the person's head towards their ipsilateral arm, their symptomatic arm, and apply gentle compression force down on their head. This will irritate the nerve roots on that side. As mentioned, always rule out cervical bony injury. The treatment is rest, activity modification, a sling if needed, ice, progressive strengthening, range of motion, physical therapy program. Serial physical exams are important. The patient may not return to play until he or she is symptom-free, has normal strength, normal range of motion, and normal sensation. For prevention, proper protective equipment, correct blocking techniques, and maintain good strength is important.